KLK 102.5 FM. Good morning to you. This is Community Conversations on KLK 102.5 FM. Cato Wonder is in the studio with you. My co-host, Mrs. Quabila Harden, is also in the studio with us today. And joining us today on Community Conversations are Jonathan and Daniel Bennett. They represent the Jonesboro Clinic, and we're going to talk about, may not be the most pleasant of topics today, but it is a serious topic that needs to be addressed in the community, is the topic of heroin and opioid abuse and some of the ways in which this scourge can be combated and treated. So with that, I want to welcome both Mr. Bennett, both Jonathan and Daniel, to the studio today. How you doing today, guys?
We're doing pretty good. How about yourself?
All right, doing good. So, Quabila, let's start us off.
All right, thank you, gentlemen, for coming. So first of all, I would like for you to explain or define what opioids is, and that word always trips me up. So I may interchange with drug dependency, so please forgive me for that. But can you please define what an opioid is?
Well, opioids are a class of drug. Opiates or opiate, if you prefer.
Okay.
Originally, they were derivatives from the poppy plant.
Oh.
That it's usually grown in the Middle East and distributed out throughout the eastern hemisphere.
Okay.
Yeah, the opium poppy is grown in Afghanistan, the Middle East, and Asian countries, and it's been used for centuries. You know, there's a resin that comes out of it that the natives of the area have chewed on, for centuries, and it produces mild euphoria in its natural state and some analgesia or pain relief. Okay. And they learned later on how to smoke that. So, there was opium smoking in centuries past, and that was very popular. When Chinese immigrants came to the U.S. to do things like work on railroads and things of that nature, they actually had dens where they would get together and smoke opium.
Okay.
Because they had, pain issues from hard labor, and of course they were lonely, and it produced a euphoric effect, which made them feel a little bit better about being alone.
Okay.
But the opium has been transformed into opiates, which are natural derivatives, things like opium itself, and opioids, which have been tweaked in the laboratory by adding other groups to it and making sort of man-made substances that are takeoffs on that natural molecule.
Okay. When did you see the rise of this? Just saying in the United... I know you said that it was...
Well, let's back up a little bit,
okay,
because I have a question in regard to what he said. Do you think that these man-made additives have made these opioids more addictive than what they would be in their natural state?
I think so, because some of the properties have been enhanced so you can get more of a euphoric effect or greater pain relief. And they do have, several different things that they produce in addition to analgesia, which is pain relief, euphoria. They also cause constipation, so that you'll see things like Imodium, which is used to treat diarrhea. They also cause some itching and constriction of the pupils and other things like that.
Okay, because the reason why I mentioned it is, the classic example is cigarettes, where nicotine was added to get people addicted to cigarettes. So I'm just wondering, did the same case apply to heroin and other opioids?
Right. It's interesting. Morphine is a very old opioid that's been used to treat pain for a long time. And the German company Bayer, we all know as Bayer aspirin.
Yeah.
One of their scientists actually invented heroin to treat morphine addiction.
How does that even, that doesn't make sense to me.
It didn't work out the way they planned for it to, but back before 1900, in the early 1900s, you could actually buy heroin and syringes with reusable needles from Sears Roebuck over their catalogs, or get them over the counter in drugstores across the country.
It was considered very safe back then. The Boston Medical Journal in 1900 actually was on record as saying that there is no danger or risk of dependency from heroin. in 1900.
Well, and also you remember during that era when Coca-Cola was first invented, it actually had cocaine in it. That's why it was called Coca-Cola.
Yeah, exactly.
Wow.
We are speaking with Mr. Jonathan and Mr. Daniel Bennett of the Jonesboro Clinic, talking about heroin and various other opioid abuses.
Right. So, wow, my mind is just really blown right now. Okay. So, when did you start to see a rise in addiction? And maybe when did some of the first addiction clinics or treatment centers become available?
Well, there have been methadone clinics around for decades.
Okay.
Prior to the 1960s, addiction was something that was treated, put that in quotation marks, by physicians in their offices who would prescribe opioids to people that were addicted to opioids to keep them from going to withdrawals. In the 1960s, of course, there was the Vietnam War, and soldiers who went to Southeast Asia were introduced to heroin, which, they were under extreme circumstances. There was a lot of stress, a lot of pain, and they used heroin there to help them cope with the problems and the pain, that they were seeing, and they brought that back with them. And that's where the importation of the drug really got to be a big thing. So heroin addiction became a major thing in the 1960s and into the 1970s.
Oh my goodness. Okay, so let's talk about, we talked a little bit off air about the different schedule. You call it schedules or different levels. Let's break some of these drugs down so that people can understand. I know we're talking amongst ourselves. You all know more, of course, than I do. But let's break it down so that people really get a full understanding of these different types of drugs, what they do, what effects they have on the body, things of that nature.
Okay. Well, the schedules that the Drug Enforcement Administration has come up with are Schedules 1, 2, 3, 4, and 5.
Okay.
Schedule 1 are highly addictive and dangerous substances that have no acceptable medical use.
Oh.
And heroin would be a good example of that.
LSD, marijuana, mescaline, ecstasy, things like that are also Schedule 1 medication or drugs.
Have these actually ever been, like LSD, has it been prescribed to someone before, or?
Actually, when ecstasy, which shows up on our drug screens as MDMA, when it first came into being, it was used by psychologists in their offices when they were doing psychotherapy with patients to get them to feel comfortable and to relax and to open up so that they would talk to the psychologist more easily and they could get to whatever the root of the problem was. But it's very addictive, and it has some properties that are unhealthy or dangerous, and so it was moved into Schedule 1.
Okay.
One thing that used to be a Schedule 3 that nurse practitioners and physician's assistants could prescribe up until last year was hydrocodone.
Oh.
And we all know that as Vicodin and drugs of that sort, usually mixed with ibuprofen or with Tylenol.
Okay.
It was rescheduled by Congress and the DEA and the FDA as a Schedule 2. So now you have to have an MD or a DO level of education and licensure to be able to prescribe that.
Wow.
So nurse practitioners can't prescribe that anymore, and it's very addictive. In fact, that's one of the main things that we treat is addiction to hydrocodone.
And where does Percocets or oxycodone, what levels do they fall in?
That's also a Schedule 2.
Okay.
It's much more potent and even more addictive than hydrocodone.
Oh my goodness. And people are literally addicted, like they feel that they cannot function without these different drugs in their systems, but not realizing they're causing long-term harmful effects to their bodies. So let's go into some more, maybe Schedule 3 and 4, and then we could then talk about some of the effects that these drugs have on the body and the brain.
Okay. Ultram or Ultracet would be a good example of a Schedule 3. Soma.
Anabolic steroids.
Anabolic steroids.
Okay.
things such as testosterone, which can be injected.
Okay.
There used to be a pill form, but it caused so much liver damage that they took the oral formulation off the market. It also comes in a gel that one could rub on their skin. It gets absorbed transdermally.
Okay.
Schedule 4s or things like Soma, carisoprodol, which is a muscle relaxer.
Okay.
Schedule 5.
Xanax is a Schedule 4 as well.
A Xanax?
Xanax is Schedule 4.
Now, Xanax is mainly used to treat what?
Anxiety.
Okay.
Typically, yes.
Yeah. Other medications like that would be clonazepam or Klonopin or Valium, which is diazepam.
Okay.
And I think I may have misspoke. I think I said that Ultram was a Schedule 3. It may be a Schedule 4.
It's a Schedule 4. Yeah.
And
It's a Schedule 4.
And what is Ultram used to treat?
It's a mild sort of an opioid that does treat pain.
Okay.
And it has other similar effects, but it's not quite as strong, not quite as addictive as hydrocodone or oxycodone.
Okay. So,
Once again, we are speaking with Jonathan and Daniel Bennett of the Jonesboro Clinic, and we are talking about different drugs and their effects and treatment and other things as well. This is Community Conversations on KLK 102.5 FM.
okay. So I want to talk about some of the effects that these different drugs have. I personally have taken muscle relaxers, and at one point, I must admit, it was getting to the point, I'm not going to say addictive, but I felt that I needed to take one even when I wasn't in real pain to just function, like to prevent the pain. Because some people have have the misconception that, okay, if I take a pain pill before I hurt, well, then I won't hurt. But then they get addicted to that, like you said, euphoric feeling, that high, I guess you say, you get off of the drug itself.
Yeah.
Right.
Well, at this point, it's probably a good idea to mention the difference between addiction and dependence.
Okay, please do. I'm so sorry. Jump ahead.
So the main difference between addiction and dependence, dependence is characterized by a normal functioning of the brain or the body when the chemical is present.
Okay.
So that's the normal feeling. There's generally no euphoria. And when the chemical is removed, that's when the person would go into withdrawal.
Okay.
Addiction is primarily dependence with a seeking behavior coupled with risky kind of behavior. So anybody who's willing to break the law to get the chemical, the substance, anybody who's willing to forgo normally pleasurable activities, such as spending time with their family or going to work, that kind of thing. Anything that disrupts your normal life because you're seeking the substance.
Okay. So at your clinic, and I know we're not going to get too deep into the types of treatments that you specifically offer, but we do want to talk about treatments in the
industry.
Yes, but what do you deal? Do you deal with both dependency and addiction at your clinic?
Definitely.
Okay.
Definitely.
Let's frame it like this, instead of saying your clinic, like in your industry that you work in, the industry of drug treatment. People who all over the country that work in this industry, like the way that they would approach treatment. I think that's a better way to frame it.
Okay. You can just say
I mean, basically, you've asked the question. I'm just giving the frame of reference on how they tend to address it.
Sorry, go ahead.
Well, in broad categories, there are abstinence treatments. Now, there's medically supervised detox or detoxification, where you go to usually an inpatient setting and you get the drug out of your system.
Okay.
That can be dangerous. Now, it's very, very uncomfortable to detox from opioids. It can be, like in the case of alcohol, it can actually be deadly to detox. I mean, you really, if someone has been abusing alcohol at high levels for a long period of time, they definitely need medically supervised and medical intervention and detoxification. And that's why, when I was a student working at the Veterans Administration, they would actually keep beer and alcohol drips at the hospital, because the veterans, usually Vietnam veterans, would come in. They would have many years of alcohol dependence and abuse. they would go into delirium tremens or DTs if they didn't get the alcohol, which could have resulted in death. And, it became apparent, especially with individual patients after a while, that they were going to begin to drink as soon as they were discharged from the hospital again. So they would just prevent death and morbidity from withdrawing from the alcohol while they were inpatients. But detoxification is getting the drug out of the system, and it's a little bit more hands-on or critical than rehab, which could be either inpatient or outpatient.
Okay.
Now, what would go on in a typical rehab facility? How would a person be treated?
Around here, there are not a lot of medically supervised rehabs. White River Medical Center has one that has more of a medical type of approach. But you also see rehabs run by lay people around here where they do drug testing. They keep the drug away from the campus where people are sleeping.
Okay.
And they prevent the people from going out and getting the drugs or from receiving the drugs from visitors.
Okay.
And they do, mostly spiritual approaches, prayer, Bible reading.
12-step type of programs.
Okay.
Working with their hands, things like learning carpentry or doing carpentry. And those are popular. They usually take from 30 to 90 days.
Okay.
Some even longer. Some people go there and stay for several months. The problem with that is, unless there is follow-up counseling after the discharge or even medication-assisted treatment, there's a very high rate of relapse, up to about 92%.
Oh my goodness! And I was going to ask you later on about statistics. What have you seen? What have you personally seen or experienced as far as once someone has gone through a full course of treatment? What is the likelihood of their success?
Alcoholism is a good analogy there, because there are people who have been addicted to alcohol for years. Mm-hmm. They go to AA or a 12-step program and they become abstinent. They always refer to themselves as a recovering alcoholic, okay, even if they have not had a drink in 20 years.
Okay.
I'm a recovering smoker. I used to smoke 2 packs of cigarettes a day. There's always a chance, given some sort of a calamity or catastrophic problem, I might want a cigarette again at some point in the future. But I've not been a smoker in 12 years, so I'm a recovering smoker.
Okay.
So your personal experiences can help with your work in the field of treating others.
Absolutely.
You can give them an example to relate to of someone who has had to battle an addiction and get over it.
Right.
Once again, we are speaking with Jonathan and Daniel Bennett of the Jonesboro Clinic. They are talking treatment for heroin and other opiates, the effects of them and what they can do to you. We got about a minute and a half before we go to break. We have a quick question that we might can knock out.
Well, just wanted to see if you could list some other treatment options.
Sure. Beyond detoxing or rehabilitation services, there's medication-assisted treatment,
okay,
which is generally replacing whatever the substance they're dependent on, with another less harmful drug.
Okay.
Methadone clinics or that kind of a thing.
Okay.
Buprenorphine clinics or that kind of a thing. There's also counseling. Counseling is an important aspect of any substance abuse treatment and is usually combined with other forms to make it more
efficacious.
Yes.
Okay. Have you found that people are resistant at first? Well, for most of the time, yes. But
some people are, yes. Some people are not there because they want to be. Mm-hmm. They're there because family or friends have brought them there.
Do you all ever have any court-ordered situation?
We don't.
That does happen. Typically, they send them to a detox or a rehab because they want them to go completely cold turkey, remove the ability to be tempted.
Okay.
All right. And with that, we're going to get ready to go to break. We are speaking with Jonathan and Daniel Bennett of the Jonesboro Clinic, talking about opioids, heroin, and various other illegal drugs and the effects and treatments of them. We'll be back. This is Community Conversations on KLEK 102.5 FM. And we're back on Community Conversations on KLK 102.5 FM. Cato Wonder is in the studio with you, joined by my co-host, Mrs. Quabila Harden, and we are joined by Mr. Jonathan and Mr. Daniel Bennett of the Jonesboro Clinic. We are talking about various drugs, drug abuse, treatment options, how just, I guess, everything drugs. Not the prettiest topic here on Community Conversations, but again, one that is necessary for the community.
Yeah, thank you, gentlemen, for joining us. And I asked you to come and talk about this topic because I know several people that have been addicted, truly addicted to different drugs, prescription drugs specifically. I watched a video and I shared it via Messenger. I don't know who replied. Was it you?
I think that might have been me.
There was a video that was made about how, okay, basically people go to the doctor. They get one prescription. Well, they like it, or they feel they need it. They go back again. Well, there are some doctors who, just because they like the patient or they take every little sob story that the person gives them, they're just going to keep writing those scripts and over. Well, if that doctor won't do it, then they'll find another doctor who will, who doesn't know their history, and the cycle continues until the point where the person is at the point of no return. Now they're needing treatment, whether they seek it themselves or, like you said before, Jonathan, their family has intervened and said, okay, you need to get some treatment. So we live in a society where sometimes we get pushed, medications are just pushed on us. There are doctors who are relaxed in the regulation of just writing these prescriptions. Right. And I'm sure that you all probably have seen that a lot in the industry, in the treatment industry, that there are some doctors who just have no, I don't want to say they're immoral. I hate to say that.
It's hard to keep track of drug-seeking behaviors.
Well, let me give an example to highlight what Quabila was talking about. Like, for example, famous athletes, what they may do is, because they're famous, they may have doctors in various states that are fans of them. So every time these famous people travel to a new state, they've got a doctor in every city that'll write them a separate prescription, and they can accumulate large numbers of these prescription meds to feed their addictions.
Mm-hmm. Sure. That kind of behavior is typically called doctor shopping.
Doctor shopping.
It's when you go to multiple doctors for the sole reason of getting the same or similar prescriptions over and over again. Cough syrup is a popular one that's tried around here, and that one's kind of an easier one to get because if you can very easily fake a cough, and if somebody's coughing, cough syrup usually helps. But the doctor shopping does happen within the state as well as without the state. We're, in the Delta area. We're in a tri-state area, basically. Mm-hmm. It's not that difficult for some patients to go to Missouri or Tennessee. And it's a little bit harder to track that kind of behavior in patients.
Okay.
Typically, they'll have records of an injury, so it appears legitimate to a lot of the physicians who are prescribing. Physicians in the past, in the mid '90s, I think is about when it started. Talking about the fifth vital sign, they were encouraged to treat pain as the fifth vital sign. Now you have
there's actually a law in Arkansas that says that patients have a right to have their pain treated, and there's not a lab test or an X-ray for pain. If somebody tells you that they're in pain, how can you say they're not? Because you don't feel what they feel. Now the question is. A pinprick is very painful to some people, while, major trauma might not be as painful to others. I was working in an emergency room one time when a 65-year-old gentleman come in and had just been in an accident, and his arm was almost completely amputated. It was literally, his forearm was literally attached to his arm, just by skin and some ligaments and the blood vessels that had not been broken. And he absolutely refused any kind of pain medicine whatsoever. But people with diseases such as fibromyalgia, you can put 2 pounds of pressure per square inch on certain parts of their body and they feel pain.
Okay.
So people experience pain
in different ways and at different levels. And when people are withdrawing from opiates, they do actually experience pain. So,
in a manner of speaking, they're getting pain treated, but it's actually mistreated. Or
okay.
inappropriately treated.
And I want to go back to something you all brought up earlier with these man-made, more synthetic painkillers, opioids. Do you feel that they have an long-term adverse effect on the body, meaning they could be creating more problems than they initially are supposed to be treating?
Definitely. A lot of times when you have prolonged chronic use of prescription painkillers or non-prescription painkillers, any opiate or opioid,
Okay.
You do build up a tolerance
Okay.
to them, so they have less analgesic effect. Certainly less euphoria, so that tends to increase the dose that both dependents and addicts will seek out.
Okay. Now, what are some, if someone has a concern that their family member is addicted or dependent, what are some signs and symptoms to look out for? I know we touched on it a little bit, but what are some like real signs and symptoms to really pay attention to? Or are there any, really?
Well, it varies, but essentially, if people will miss work, if they'll miss family functions or avoid going to school so that they can do whatever they have to do to obtain the substance that they're dependent upon or addicted to, that's a key indicator right there. If someone always seems to be seeking or has access to pain medication long after the pain or the condition that caused pain should have subsided, that's another indication.
Okay.
And, of course, if you see withdrawal symptoms, which could be shaking, chills, goosebumps,
some flu-like symptoms, runny nose,
Really?
tearing eyes,
dilated pupils,
goose pimples is a
So it's
big-
like little bumps that are just,
Yes.
okay. Wow. Okay.
and even nausea, vomiting, and diarrhea.
Thanks.
Another thing that you might look out for behavior-wise, Dr. Bennett was mentioning, they always seem to have access to the medication. If they're carrying their bottle around and they're not going on a prolonged trip,
Oh.
if you see, kind of like Dr. House behaviors where they pop the
yeah.
medication without needing water or they chew it,
Oh, my.
that's definite behavior to look out for.
Once again, we are speaking with Jonathan and Daniel Bennett of the Jonesboro Clinic, talking about drugs, treatment, and various other topics related to this issue. This is Community Conversations on KLK 102.5 FM.
Okay. I want to ask, I've been becoming more and more interested in policy as it relates to, a variety of fields. Do you foresee over the course of time, either on the state level or on a federal level, some policies being changed when people go to the doctor, their records will then become available to any doctor anywhere that they go to? Just, if that person decides to do some doctor shopping, as you so called it, that next doctor will have access. Once they sign the release form, they have access to their medical records, and they can see, you've already been prescribed this once, this many times this year. Because of the policy, I can no longer prescribe this.
Well, there's a tendency to try to control drug-seeking behavior.
Okay.
Now, as far as medical records, without a patient's express written consent through a request, a doctor cannot have access to their medical records. However, doctors in almost every state now can access the prescription monitoring program.
Okay.
Now, there are different ones for each state. Some of them allow cross searches to different states. In Arkansas, I know that you can search in Kentucky, Missouri, Tennessee, and Mississippi. I'm not sure about Louisiana, but I believe that they can. And he can look up, what you've been prescribed, if it's scheduled, what pharmacy you've gotten it at. They can also who prescribed it. So that we can check that now when you come in to see the doctor, and simply consenting to treatment is consenting to a doctor looking at the prescription monitoring program.
And Tennessee is actually a lot more engaged in that sort of activity. In fact, if I were working in an emergency room in Tennessee if someone comes in complaining of pain and they ask for a prescription for hydrocodone or Dilaudid or oxycodone, I have to check that state's PMP system, or I would be breaking the law.
Okay.
Now, that's not the case in Arkansas yet, but...
And wouldn't that be to you a red flag if they're asking you for a specific med?
It usually is.
Because, I mean, if they say, can you give me this instead of, I'm hurting, doctor, just give me something to stop the pain.
And another red flag is people that are allergic to non-steroidal anti-inflammatories like Toradol or ibuprofen.
That are allergic to those.
If they're allergic to anything that's not narcotic,
if they claim they're allergic, is what he means.
Right.
Wow. So that means they want something really strong, the prescription, the good stuff.
Yeah,
okay.
The good stuff.
Okay. Well, let me ask you this. I've had some surgeries before, and the doctors have used, different types of painkillers. I remember once having a morphine drip, and fortunately, I wasn't in as much pain as I thought I would be in, so I didn't have to use it as much. What will cause doctors to prescribe certain things for certain, is there some type of guideline that you all use? Say, okay, well, this person has this particular issue, I'm going to prescribe this.
Well, that's kind of an individual thing up to the doctor.
Okay.
Sometimes the doctor will assume, if I had this sort of surgery, I would need this much pain control.
Okay.
And that morphine drip you were talking about, that's personally controlled anesthesia where you have the little trigger, the little push button in the hospital. And what happens is that pump will lock you out for 15 minutes or 20 minutes or 30 minutes.
Okay.
And then when that lockout time passes, if you're feeling pain, you can press that button and you'll get a dose of morphine. A lot of surgeons will prescribe opiates and opioids for post-operative pain. Mm-hmm. Some will not.
Okay.
And there was a study done over 10 years ago, and there are studies done every year. Some of them conflict with other studies, but at least one study that I read said that a lot of post-operative pain would be controlled better with Tylenol and ibuprofen than with hydrocodone.
Okay. And so do you feel that some people, because they take the prescription strength just so they can sleep or rest versus taking the over-the-counter one, which is only going to subdue the pain and then they can still function on a normal basis?
Some patients do seek that sedative effect from prescription painkillers. It's kind of common. They'd rather be dreaming or not dreaming, as the case may be, than be awake and experience that pain. One thing that patients can do, if that's a thing that they're worried about, you can ask your doctor about pharmacogenetic testing. Pharmacogenetic testing, they draw a little bit of blood, or usually they'll scrape some of the cells from both of your cheeks and they'll send that into a lab, and you can find what medications work best for you, because Dr. Bennett will be the first one to tell you medications work differently for different people.
Okay.
That's largely a genetic thing.
Wow.
I've actually had it done. I was really happy to have it done because I know what works and what doesn't.
Okay.
And there are a couple of caveats to that, too. Jonathan mentioned cough medicine a little while ago. Mm-hmm. Usually when someone asks for cough medicine, they want cough medicine that either contains hydrocodone or that contains codeine.
Okay.
And the thing with codeine is it's not really a good cough suppressant normally. In fact, there are no really, really good cough suppressants. A lot of that is a psychological effect. People think if they take cough syrup or cough medicine, they actually believe they're coughing less, but if you count the number of coughs that they have with and without the medicine, it's usually about the same.
Okay.
But now some people have an enzyme in their livers which converts codeine into morphine. And I'll give you two examples of what can happen when that takes place. There was an older gentleman in a hospital in New York. He was given Tylenol number 3 for pain, which is Tylenol or acetaminophen with codeine. It also comes in Tylenol number 4, which is a little bit stronger. And he was given a cough suppressant containing codeine. He was a hypermetabolizer that converted almost all of that codeine into morphine, and he died of a morphine overdose.
Oh, wow.
And there was another incident of a lady who was breastfeeding a baby in Texas. She was taking Tylenol number 3 for breast pain, or what we call mastodynia, and she had taken enough of it that when her liver had converted almost all of it into morphine, the baby that she was breastfeeding died of a morphine overdose.
Well, that's definitely tragic. Once again, we are speaking with Jonathan Bennett, and it's Dr. Daniel Bennett. Sorry, I didn't mean to address you by your proper title.
Okay.
We just asked for the names. I didn't know what you were.
Most people call him Dan.
So you are actually a medical doctor.
Yes. Uh-huh.
Okay. So Dr. Bennett and Mr. Bennett, let's talk about the link between opioids and crime. As you mentioned, as Jonathan mentioned, when it gets to a point beyond dependency to addiction, to where you will do things that you normally wouldn't do in order to get it. So just from your observations in the field, talk about the link between opioids and crime, as well as other risky behaviors. Like, for example, you may have some people who may resort to prostitution or whatever to get the money or whatever to get the drugs that they need. So let's talk about it from that standpoint and get your thoughts.
Okay, well, as far as crime, as an incentive to commit crimes, they're either a seeker would either be looking for the medication directly or for the funds to acquire the medication. Usually when they're looking for the funds, they're getting it from an unlicensed street pharmacist, a dealer somewhere. If they're looking for the medication primarily in breaking laws, that could just be as simple as doctor shopping, going to multiple doctors looking for the same medication before you've run out of the medication from legitimate use. Or you could pharmacy robberies. So, people going in with weapons and holding up pharmacies and only requesting medications. There's a pharmacy that we're very close to that has been robbed on several occasions. And, one occasion they were robbed. The gentleman took around 150 to 200 oxycodone, and then he went outside and attempted to kill himself. Which that's another issue, is a lot of patients get to the point where they feel that they can't handle their dependency, their pain, or their addiction, or all three, and they try to look for a way out. That's very unfortunate when that happens.
So the gentleman actually took the pills that he had stolen
in attempted suicide.
Correct. He went to the sidewalk. He didn't even go across the street. He was looking to end it quickly.
Oh my! So that person needed more than just medical. Well, I mean, he needed psychiatric help at that point.
Yeah, counseling definitely would have benefited him. An ounce of prevention is worth a pound of cure, as the old saying goes. The earlier that somebody can get help, the more effective every treatment is going to be. And normally treatment is more effective when you kind of mix and match. Okay. Start with one rather than the other. And some people are kind of restricted from what treatments they can get because of their life situations.
Okay.
Rehab's not easy to get into if you have to leave your job.
And kind of as we get ready to wrap up this segment, we've got about 90 seconds left. Since we're on this topic, do you think that there needs to be more of a focus on rehab for people who might wind up in jail for these kind of addictions? Do you think that there needs to be a greater effort to rehabilitate them either while in jail or when they get out, so that when they do get released, that they're not, the first thing that they don't have on their mind is getting their hands on more of the drug?
Right. Rehabilitation should be through whatever treatment path, should be the first goal. A model such as Portugal would probably do a lot better in the United States. In Portugal, they decriminalized the use of all drugs.
Okay.
But they did not, to my knowledge, decriminalize the sale or production of drugs.
Okay.
They have needle exchanges in Portugal to prevent death, and they have counselors go out with some police escort to offer help to people who were on the streets and who are using. And since 2001 in Portugal, when they did this, they haven't had a single overdose.
Well, I actually got a unique question about that, but we're out of time on this break. So when we come back, I'm going to ask that question. We are speaking with Mr. Jonathan and Dr. Daniel Bennett of the Jonesboro Clinic, talking about drug use, abuse, and all other related issues. You're listening to KLEK 102.5 FM. And we're back on Community Conversations on KLEK 102.5 FM with our guests, Mr. Jonathan and Dr. Daniel Bennett of the Jonesboro Clinic. We are talking about various illegal drugs and all of the other issues related to it. Before we went to break, Jonathan was talking about the model of Portugal, where they have decriminalized the use of drugs, but the sale of drugs over there is still criminal, which I think kind of begged the obvious question is, well, how do, not saying that we're encouraging drug use, but in a model like that, how would they get the drugs if it's okay to use it, but it's not okay to sell it? I'm just kind of curious.
Well, the process was kind of developed in tandem by both economists and physicians. The idea is to reduce supply and ease demand. You want to ease demand gradually because that sudden stop is what causes deaths. And any time that you have a black market for anything, any substance, that black market is inherently more dangerous than if it was open on a free market. But the idea is they want to reduce the amount of users of the medication or the substances and have them seek out alternatives. I know that they've made a medication known as naltrexone. It has a brand name of Narcan. It's used in emergency rooms here in the United States, and it reverses opioid overdose, and it has a fairly instant effect. I haven't seen it personally, but I've read of cases in emergency rooms where, a person would come in, a young lady specifically in this case came in. She was clinically dead for a few minutes, and the doctor used Narcan or naloxone, and she immediately perked right up, said, "I have a headache," and she hadn't realized that anything had happened.
Wow.
Well, I've used that medication on overdoses that have come into the emergency department before, and it has a dramatic effect. You can actually see someone's pupils going from pinpoint to dilated in just a few seconds.
Okay.
But, Jonathan brought up an interesting point as far as supply and demand is concerned. Next year is going to be an interesting year because, right now, drugs are more plentiful, more easily obtained, more potent, and less expensive than they have ever been before. And the DEA and the FDA have recently ordered pharmaceutical manufacturing companies to cut production of oxycodone, hydrocodone, and other opioid painkillers by 25% in 2017. So the street value of those drugs is going to go up significantly, and the demand for heroin is also going to go up right along with it.
And unfortunately, that's probably going to mean the crime rate is going to go up as well.
Definitely.
Heroin is actually still on the street. You don't
if
hear
you
much
remember,
about it.
Well, if you remember a couple of our interviews, I think it may have been a couple of interviews ago that we had with Chief Elliott. He mentioned that that was becoming more of a problem here in Jonesboro.
Yeah, to talk on that a little bit, heroin overdose rates have doubled in 28 states between 2010 and 2012. And in 2014, there were 28,000 deaths from opioid overdoses. That's from all opioid sources, both heroin and prescription painkillers.
Oh my goodness.
Let's transition once again. We are speaking with Jonathan and Dr. Daniel Bennett of the Jonesboro Clinic, talking about various drugs and their effects and other issues as well. And one of those issues is, how does it affect family, friends, and loved ones? Let's, from what you all have seen in the industry, talk about how when someone is addicted, how it affects those close around them, and what general resources are available for those who may know someone that needs help, and especially in a situation where the person may not even be willing to help themselves.
Well, one thing, that you see with any sort of addiction, it could be gambling addiction, sex addiction, drug addiction. You see families break up, you see divorces, you see people losing their houses and their jobs. And I know doing medication-assisted treatment, I've had dozens of people tell me that I've saved their families, I've saved their marriages, I've saved their careers, I've saved their lives. And I actually feel like I'm doing more good now providing medication-assisted treatment to outpatients than I ever did working in the emergency room trying to save people's lives. So you do see, that there are a growing number of places to get help. And without that help, you're often looking at shortened life expectancy, spread of diseases such as hepatitis C and HIV, which are, especially in the case of hepatitis C, is practically an epidemic now.
It really is. It's very, very common. It's become increasingly common in the last 2 years. I think hepatitis rates have gone up about 25% in users, specifically needle users.
Mm-hmm. Because we talked about earlier, how people are so desperate to get it, they would do anything. So they're not checking who used that needle, where it came from.
Right. Risky use behaviors is one of the characterizers of addiction versus dependence.
Mm-hmm.
All right. We got about 2.5 minutes. We want to thank you, gentlemen, first of all, Mr. Bennett and Dr. Bennett, for stopping by to educate our listeners on drugs and their effects and other things. Is there anything else that you would like to just say to the listeners that may need help or may know of someone who may need help?
Definitely. Your first resource in any health issue should always be your doctor.
Okay.
You can always go to your doctor. Your doctor may know of or will usually be in direct referral contact with a provider who can help, be it rehab, detox, medication-assisted therapy, and counseling.
Okay.
You can also go to the Substance Abuse and Mental Health Services Administration's website. That's samhsa.gov.
Could you give it one more time?
Sure. It's www.samhsa.gov. There's a treatment locator on their website to help find a provider in any state of the union or territory of the United States. And you can search it by your home, where you live, zip code, county, and state.
All right. Well, Mr. Bennett and Dr. Bennett, want to once again thank you guys for stopping by and providing this valuable information for the community. We hope that it helps someone. So if you are listening and you are addicted, or you know someone that is addicted, definitely encourage them to reach out and get help. There are various organizations and places available. This is Community Conversations. You guys be blessed and have a great day. This is KLEK 102.5 FM.